It is my pleasure to speak to you, dear students, about chronic kidney disease. This is one of the most important and essential topic. And chronic kidney disease, we can write textbooks in chronic kidney disease. This is why I'm going to focus on the risk factors for chronic kidney disease, because even if we don't have studies or clinical trials to prove the effect of modification of risk factors on the incidence of chronic kidney disease, we will be happy to modify all these risk factors if we can. So I'm going to speak about the risk factors and their incidence, but I prefer to start with this case. It is a virtual case. This is a 65-year-old male patient, diabetic for 15 years, blood pressure, the patient is hypertensive, almostly blood pressure 160 over 100, obese, body mass index 38 kilogram per square meter, creatinine is high, 2 milligram per deciliter, estimated GFR. Estimated means that we calculated GFR based on formula is 35. Albumin creatinine ratio is 500 milligram albumin per gram creatinine. Hemoglobin is 9 gram per deciliter. He is a smoker and suffering from sleep disorders. So if this is the case, the questions on this case, what is the stage of chronic kidney disease? So one of the most important teaching point in this lecture is to know how to categorize the stages of chronic kidney disease, how to classify definition and the classification of chronic kidney disease. Second point, which is the preferred formula to estimate GFR, to calculate GFR. And if this is the case scenario, what are the risk factors that this patient has, if this is his data? So let us go to the presentation, and at the end of the presentation, I'm going to answer these three questions. To start with, the regarding definition of chronic kidney disease, I think it is very complex figure, but we'll take it part by part. So we have, if you look here, this is the GFR, or calculated GFR, or estimated GFR. It is above 90 milliliter per minute, and this is a normal value. 60 to 89, 45 to 59, 30 to 44, 15 to 29, and less than 15. What are these values? What does it mean? This is the categorization. Here, estimated GFR is normal. So why I put it here in the definition of chronic kidney disease? If I have a person with estimated GFR above 90, can I say this is a person who have chronic kidney disease? The answer is, if there is nothing in the urine is perfect normal, no albuminuria, no hematuria, nothing, ultrasound is perfect, so this is a normal person. This is why you will find this is the Greenland. Greenland means we don't have chronic kidney disease. So if estimated GFR based on the formula is above 60, we are in the Greenland if the person has normal albumin excretion. If the person is in the normal or albuminuria 1. Albuminuria 1 means he has normal albumin excretion. To be honest, if we have estimated GFR in this range, within this zone, but we don't have albuminuria, but we have persistent hematuria, this is the same. It is chronic kidney disease. So to say chronic kidney disease in persons with preserved estimated glomerular filtration rate, we should look at urine analysis. either persistent, and you should put many lines under the word persistent, because I can do urine analysis for a person and I can find some are red cells or increase the albumin excretion in this time point. And after repeating urine analysis, then I can find it normal. I cannot categorize this patient as a patient with chronic kidney disease. Again, to say chronic kidney disease, we have either estimated GFR less than 60, so all these persons have chronic kidney disease, so long as estimated GFR is persistently less than 60 milliliter per minute. Persistent means that we follow the patient over 3 months. So 3 months with persistent low GFR less than 60 milliliter per minute, this is a chronic kidney disease. If it's above 60 milliliter per minute, here in 1 and 2, I cannot say stage 1 and stage 2 chronic kidney disease, except if I have abnormal urine analysis. So the estimated GFR above 60 was totally normal urine analysis, normal ultrasound of the kidneys, nothing, this is a normal person. But if I have estimated GFR above 90 and the patient has well-documented polycystic kidney by ultrasound, even if urine is normal, this is a state of chronic kidney disease. If estimated GFR is above 90, this is stage 1. From 90 to 60, it is stage 2, provided that we have parameters denoting kidney damage, either persistent albuminuria, persistent hematuria, or radiological evidence of kidney disease. This is why if albuminuria is abnormal, A2 or A3, you will find the color is not green. So here I have chronic kidney disease stage 1 because estimated GFR is above 90 milliliter per minute, and we have albuminuria A2 or albuminuria A3. To say albuminuria, we look at this. If albuminuria is less than 30 milligram albumin per gram creatinine, or less than 3 milligram albumin per millimole creatinine, here this is a normal albumin excretion. If estimated GFR above 60, this is a normal person. If we have albuminuria in this range, between 30 to 300 milligram per gram albumin creatinine, or 3 to 30 milligram albumin per millimole creatinine, so this is A2. A3, if it is above 300 milligram per gram or above 30 milligram per millimole. So if we have A2 and estimated GFR above 90, this is a stage 1 chronic kidney disease. And if it is between 60 to 90, less than 90, and we have A2 or A3, this is stage 2 chronic kidney disease. But if we have A1, albuminuria, and no hematuria, nothing, this is a normal person. Greenland is a normal person. Then, even if we have normal albuminuria, normal excretion of albumin, and GFR is less than persistently for more than 3 months, less than 60, we are in a stage 3. If it is between 60 to 30, stage 3 is divided into 3A and 3B based on this cutoff point of GFR. If estimated GFR between 59 to 45, it is 3A. If it is here 44 to 30, it is 3B. Then if estimated GFR in the range from 15 to less than 30, it is stage 4. Stage 5, that is known as kidney failure, if estimated GFR is less than 15 milliliter per minute. So I think it's now clear. This is how we classify chronic kidney disease into 5 stages. And the definition is based on the cutoff point of estimated GFR, and it should be persistent for more than 3 months on the value less than 60 milliliter per minute, or even if it is above 60, we should have parameters denoting kidney damage like persistent abnormal urine analysis from albuminuria, and as shown in this slide, or persistent hematuria, or presence of radiological or biopsy, whatever the parameters of kidney damage. I think it is clear. Chronic kidney disease progresses from stage 1 to 2, 2 to 3. So this is how progression is defined. So progression means worsening of kidney function during the follow-up. So we can progress from the lower stage to the higher stage. And in this slide, you will find here, this is the color code or heat map. We have green, normal, yellow, abnormal, orange, and red. The color here reflects risk factor. The darker the color, so red is dangerous than orange and then yellow. The darker the color, the higher the risk of progression of chronic kidney disease, occurrence of acute kidney injury on top of chronic kidney disease, occurrence of cardiovascular problems, and mortality. This is the most important slide. This is why I give it this time for explanation. Again, to define chronic kidney disease, we should have either persistent lower estimated GFR less than 60 milliliter per minute for a period more than 3 months, persistent, or even if estimated GFR is above 60, but with the presence of either A2, albuminuria 2 or albuminuria 3, or persistent hematuria, or evidence of radiological abnormality denoting kidney damage, or histopathology denoting kidney damage. All these are criteria for defining chronic kidney disease. According to the level of estimated GFR, we categorize and classify chronic kidney disease into stage 1, 2, 3, 4, and 5. What are the causes of chronic kidney disease? As you see, this is the United States Renal Data System, the last report, showing that the most common causes of end-stage kidney disease for patients who are supported by dialysis, the causes are diabetes, followed by hypertension, and this is the percentage. As you see here, the number, total number, it is the diabetes is the leading cause of end-stage kidney disease in the United States, followed by hypertension, followed by glomerulonephritis, then polycystic kidney disease, and others, or unknown etiology. In some booklet and some areas, pockets, some areas in the world, you can find infection, drug abuse, interstitial nephritis, and other causes as the cause of end-stage kidney disease. Whenever I know the causes, I think this is the starting step to combat end-stage kidney disease, to improve the care of diabetic, hypertensive, and patients with kidney disease. The most important part of this presentation is what are risk factors for development of chronic kidney disease. Risk factors for development of chronic kidney disease are categorized into 3 big categories: either non-modifiable risk factors, partially modifiable risk factors, or modifiable risk factors. If I know that this person has non-modifiable risk factors, I should be careful with him to avoid second hit or exposure to modifiable one, or I should modify the modifiable one seriously in this person because he has one factor which is non-modifiable. And if the patient has modifiable or partially modifiable factors, I should do my best to do modification to reduce the risk, even the rate of progression of kidney disease. One of the non-modifiable risk factor is the low birth weight. So the body weight at the time of birth, if it is low, this is the risk for many diseases. One of them is chronic kidney disease. So if my body weight is recorded and I know during the birth the body weight was low, I should be very careful for other risk factors. So this is one of non-modifiable risk factors. Another important risk factor, which is shown from this cohort of patients, in this cohort of patients, they followed 1.5 million person, and they considered the 2 points, I have exposure in the past history of kidney disease in childhood, and currently, and after following the patient for many years, they address the prevalence of occurrence of end-stage kidney disease. And they found that the presence of history of kidney disease in childhood is a real risk factor for adult end-stage kidney disease. So occurrence of repeated urinary tract infection in children, nephrotic syndrome in children, etc. So this is why all the time we ask for evaluating our patients about the past history of kidney diseases. One of the important risk factor, so the low birth weight, the past history of kidney disease, and the previous history of acute kidney injury, all these are non-modifiable risk factors. So if the patient has a history, past history of acute kidney injury, even in the past and recovered completely, we should be serious and learn, educate this person for the healthy lifestyle to avoid another risk factor added to him, because he is more prone to chronic kidney disease, because acute kidney injury can leave a print for chronic kidney disease. And I'm not going to bother you by the details why acute kidney injury can increase the risk of development of chronic kidney disease later on, because there are many researches and advances in this issue. So again, up to this moment, I told you that low birth weight, the past history of kidney disease, occurrence of acute kidney injury are risk factors for the development of chronic kidney disease. Aging, old age, again, it is non-modifiable. So we should be careful when we treat a senior patient, aged patient, old age patient, because he is more prone to chronic kidney disease. The question why and what happens to kidneys in the old age. You can see here, by old age, if this is the kidney of adult, young adult, and this is the kidney of old patients, you can see the difference. So the kidney ages. So both kidneys have aging print through reduction of the mass of the kidney. 20-25% between age of 30 to 80 of the mass is lost. The weight of the kidney, 10% per decade, every 10 years. Above 40, we lost 10% of the weight of the kidney. Length, kidney shrinks with age, half centimeter. Every 10 years, above 40, kidney is shortened by half centimeter. Parenchyma also is lost 10% per 10 years. What does it mean? This means that the kidney becomes smaller with age, and the function will be reduced as well. Microscopically, you can find disturbance of all the components of the kidney. I'm not going to say all these details, but kidney ages. And second important, so long as the kidney ages by reduction of the mass and the number of functioning nephrons, we can expect functional changes. GFR is reduced, but fortunately, you will find creatinine is always normal. Why? Because concomitant with the kidney shrinkage, muscle is atrophied. So muscle atrophy, and the muscle is the origin and source of creatine, which is transferred into creatinine. This is why in old age patient, creatinine is normal. But this patient is more prone to chronic kidney disease. This is why we should avoid any other hit. So dehydration, using drugs and others, should be very careful in the old age patients. One of the very important points I would like to discuss with you for functional changes in elderly persons is not GFR, but as well tubular function. So tubular function, and one of the important kidney tubular function is the ability of renal tubules to concentrate and dilute urine. The ability to concentrate or dilute urine is impaired in elderly person. What are the implication and the consequences of the inability to well concentrate and well dilute urine? The consequences are, if I cannot dilute urine well, and this person drinks a lot of water, he cannot get rid of all this water. If the patient is hospitalized and I give him overhydration, he cannot manipulate, he cannot get rid of all these fluids. So this person is more prone to overload. And if this person is unable to concentrate urine and he is now not able to drink water, he will be more prone to dehydration and damage. So this is why we should be very careful when we deal with elderly persons regarding both overload and dehydration, because both of them can occur in elderly person. Let us go to the modifiable risk factors. Hypertension. Hypertension is one of the modifiable risk factors for chronic kidney disease. So we should be careful about hypertension, to record the blood pressure and to manage blood pressure perfectly. And our current target is, according to the new guidelines, it's better to reduce blood pressure to less than 140/90 and sometimes to 130/80. And in chronic kidney disease, a non-diabetic person with chronic kidney disease and estimated GFR is above 30 milliliter per minute, we can even encourage and advocate intensive blood pressure control, even less than 120 systolic blood pressure, so long as the patient tolerate this value, to retard the progression of chronic kidney disease and cardiovascular problem. To control blood pressure, this is the drugs that can be used. The best for kidney is using angiotensin converting enzyme inhibitors or angiotensin receptor blockers. And this is the most important class of antihypertensive in chronic kidney disease, especially in proteinuric persons, because this class of drugs has anti-proteinuric effect. And then we can add other drugs like calcium channel blocker or diuretics, and in resistant cases, we can add spironolactone. If we give diuretics and the estimated GFR is preserved above 30, we can use thiazide. But if estimated GFR is less than 30, thiazide is replaced by loop diuretics. So even if it is too early to know all these details, but we should learn that hypertension is one of the important risk factors to be modified, and it can be associated with preserving of kidney function, especially if you use nephroprotective drugs. The second important modifiable risk factor is diabetes. So how to manage diabetes? This is one of my videos, and that was recorded this month about the 2020 KDIGO guidelines that was released this month in the Kidney International Journal. And just for kidney heart risk factor management of diabetic patient, this is a very important pyramid. I'd like all of you to understand and to advocate and to know from the early beginning of your career that in diabetes we don't manage hyperglycemia only, we manage everything. So it is multidisciplinary, and we aggressively modify many factors. So for all diabetic patients, here, this is what we should advise. And if you go to the video, you'll find many details. But here, this is lifestyle modification, including encouraging physical activity. It is recommended for adults to have at least 150 minutes per week physical activity. To cut down salt. So the habit of excessive salt is bad for blood pressure, bad for the kidney, bad for everything. So we should learn to moderate salt. To stop smoking, diabetic should stop smoking altogether. Lipid management, managing dyslipidemia, managing blood pressure, and managing glycemic control. So for all diabetics, we need this, all these to be addressed. Lifestyle modification, blood pressure control, hyperglycemic control, control of dyslipidemia, and stopping smoking. And then the majority of patients, we need RAS blockade. What's meant by RAS blockade? Angiotensin converting enzyme inhibitors or angiotensin receptor blocker. We don't combine them. Either ACE inhibitor or ARBs is used for treating blood pressure and for proteinuria. And the sodium glucose cotransporter 2 inhibitor. This is an important class of anti-diabetic drug that was added. It is still, since a couple of years, it's added to the armamentarium of type 2 diabetes treatment, and it has many beneficial effects. One of them is to protect the kidney. So this is the major change in the current guidelines to advocate the use of sodium glucose cotransporter 2 inhibitor for protecting the kidney of the patients. And some patients with coronary heart disease, we use antiplatelet therapy as secondary prevention, or on some patients with severe risk factors, even we can use antiplatelet as primary prevention, but we should weigh the risk and the benefit from using antiplatelet. So again, the key message from diabetes is to follow holistic, multidisciplinary approach for treating diabetes. This is how we use angiotensin converting enzyme inhibitor or angiotensin receptor blocker. This is the most important antihypertensive class to be used for diabetic patients with blood pressure, high blood pressure, and with proteinuria. But the major problem that we are afraid is the hemodynamic effects of this class of drugs on kidney function and the risk of hyperkalemia. So this is why after treating the patient, initiating this class of drugs, we repeat creatinine, serum creatinine measurement and the potassium measurement within 2 to 4 weeks. And I consider this relaxation because in the past I advised to repeat after a week. So within 2 to 4 weeks, we repeat the creatinine, serum creatinine, and serum potassium. If we don't have problems, so there is no increase in creatinine or the maximum rise is less than 30% of the baseline, there is no hyperkalemia, then we can even increase the dose. And when we increase the dose, because for each member of ACE inhibitors or ARBs, there is the initial dose and the maximum dose. For any increase in the dose, we should repeat again kidney function and the potassium measurement. If we have hyperkalemia, we should review the concurrent medication to stop them or to modify them. And we may reduce the dose of the ACE inhibitor or ARBs or stop them if hyperkalemia persists or very high level. If there is increase in creatinine by more than 30%, then we assess if there are other reasons for this. If nothing, we can reduce or stop them. So the key message is to use them and not to be rushing in stopping ACE inhibitor or ARBs for our patient. For my perspectives is to work on the preventive strategy. So I advocate every person in the community to calculate his or her risk for development of type 2 diabetes, like smoking, obesity, etc., and then to know the risk and to modify the risk for occurrence of diabetes. So primary prevention of kidney disease in diabetic patients is to prevent diabetes itself. Let us go to one of the important modifiable risk factors. I can stop here for a while to have some interactions from the audience. This is another risk factor, which is metabolic acidosis. We don't like metabolic acidosis. Usually it is neglected. The majority of doctors don't measure serum bicarbonate. We should be careful because acidosis is associated with progression of chronic kidney disease. we expect that patients with chronic kidney disease may develop acidosis, and so we should search about this. And when we correct acidosis, we will slow the progression of chronic kidney disease. So this is just to know and to put in mind the best level of serum bicarbonate, the best level. This may be an MSQ question for you. The sweet spot or the best values of serum bicarbonate in chronic kidney disease is serum bicarb between 24 to 26 milliequivalent per liter. Why? Between 24 to 26, because this is the best to slow progression of chronic kidney disease. But if serum bicarb is on the low normal, eubicarbonatemic, the patient is enjoying normal bicarbonate because the kidney does a big effort to buffer acidosis by increasing ammonia secretion. Increased ammonia secretion by the kidney is toxic to the kidney. This is why we should reduce the buffer, the workload of the kidney to avoid this excessive buffer. The best is between 24 to 26. Above 26, we will be in the load of sodium, the load of vascular, because the increased risk of cardiovascular calcification. This is why, in one sentence, the best serum bicarbonate in chronic kidney disease or sweet spot of serum bicarbonate is between 24 to 26 milliequivalent per liter. Don't forget metabolic acidosis. This is one of the modifiable risk factors. If we start earlier by changing diet or giving bicarbonate, this will have a positive effect. One of the very important and crucial is the abusing of drugs. And here I'm just enumerated some of them. Proton pump inhibitors. I'd like to stop here to ask you what's meant by proton pump inhibitors. One of the important classes of the drugs that reduce HCl is proton pump inhibitor class. I don't like the abuse of this class. They are perfect to deal with peptic ulcer, with severe reflux esophagitis, but abusing them is associated with many, many adverse events, including, as you see, non-kidney and kidney disease dysfunctions. Non-kidney events, atrophic gastritis, vitamin B12 malabsorption, cardiovascular disease, Clostridium difficile infection, community-acquired pneumonia, dementia, gastric cancer, osteoporotic fracture, kidney problems, including electrolyte disturbances, hypomagnesemia, hypocalcemia, acute kidney injury, acute interstitial nephritis, incident chronic kidney disease, kidney failure, and more importantly, the abusing of this class increase mortality, increasing due to cardiovascular or other causes of mortality. This is why, yes, we can use them whenever they are critically indicated for short period of time, and to learn to stop them, deprescribe them. I'm not going to give these details to you, but providers should limit the dose and duration to a minimum necessary, and consideration should be given to monitoring kidney function and serum magnesium level, especially important in patients using concomitant diuretics, because hypomagnesemia will be more common if the patients are treated by diuretics as well. So it is time for deprescription. Deprescription means when the indication is not present, we should stop them. Abusing this class of drugs is associated with increased risk of many diseases, including chronic kidney disease. Non-steroidal. As nephrologists, we don't like non-steroidal anti-inflammatory drugs. And whenever they are needed, they should be in small dose. Blood pressure should be monitored. Kidney function should be monitored. And this is why we should educate people against the side effects of non-steroidal anti-inflammatory drugs. They can be used cautiously in chronic kidney disease for short courses, for smaller doses, and not for long duration. even antibiotics. This is, I think this is a very new data for you. We know that antibiotics may be associated with allergic diseases, yes, anaphylaxis, okay, antibiotic resistance, maybe, but antibiotic to be associated with development of kidney stones, I think it is new for you. Do you know why? So this is a very funny data that the antibiotic may increase stone formation. These are two articles, as you see. The link between the use of antibiotics and the development of urinary stones may be explained by the effects of antibiotics on gut microbiome. So in our gut, we have many millions of innocent bacteria. They can feed on oxalate. So if I kill this bacteria, gut microbiome, by using of antibiotics, then we will be in the flood of oxalate, and oxalate will be absorbed, and absorption of oxalate may increase stone formation through increased oxalate deposition in urinary tract. So the main mechanism is antibiotics can kill oxalate degrading organisms. So gut microbiome, should we know that we are living with microbiome, and the healthy microbiome is essential for our life. If we disturb the gut microbiome by many bad habits, like avoiding lactation, using antibiotic in early childhood, all these are very bad for the gut microbiome that may be associated with diseases. One of them is chronic kidney disease. Sleep disorders. I think we should learn about the healthy sleep, healthy in both quantity and quality. So what is the best time, the amount of sleep? Between 5 to 8 hours. Less than 5, above 8, these are associated with increased chronic kidney disease. So lack of sleep or excessive sleep are both bad for the kidney. Second point, interrupted sleep is bad. So this is the quality of sleep. So we should learn how to sleep, when to sleep, for how many hours we should have sleeping. Sleeping is perfect. Why sleep disorders is associated with kidney disease? This may be due to many hypotheses, including sympathetic overactivity. Herbal remedies or supplements. Supplements, I advocate, because all of you are in the early beginning, you are still young adults, please don't have supplements. Vitamins, everything may be toxic for the kidney, except if you have definite vitamin deficiencies, it's okay. But supplements, abusing supplements is bad for the kidney. For herbal remedies, Chinese herbal remedies, they may lead to kidney injury by many mechanisms, including intrinsic toxicity. And the word adulteration, adulteration means herbal remedies may be mixed with toxins. Adulteration means mix. The herbal remedies are mixed with non-steroidal diuretics and laxatives. All of these can have toxic effect on the kidney. So I have one word: no herbal remedies. Smoking is nephrotoxic. Smoking is kidney poison. And here I'm not going to highlight on the publication of smoking and kidney, but second-hand smoking, even passive smoking. If you sit together in the same place with the smoker, you are more prone to kidney disease. So this is why you should stop smoking and don't sit beside smoker. So this is a modifiable risk factor for kidney diseases. Obesity and nutrition. This is one of my videos, including many details about nutrition for those who are interested in the nutritional approach, because diet may lead to hyperfiltration of the kidney with subsequent damage, especially heavy protein diet. Diet with that is associated with oxidative stress, animal proteins, processed foods, inflammation, or increasing acid load. So the diets rich in hard cheese, eggs, animal proteins are acidic diet, but the diet rich in fruits and vegetables are alkaline diet. This is why we advocate plant and fruits and vegetables. We should combat obesity, and obesity is measured either by body mass index or waist circumference, because obesity is a real risk for chronic kidney disease, either directly or indirectly. This is why in the World Kidney Day, one of the important brochure is, and banner is to encourage, advocate weight loss for obese persons. This is a very important DASH diet. Do you know what's meant by DASH diet? Diet approach to stop hypertension. This is a name. It includes these components: 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 components. We try to be in the target, or at least in the intermediate target, because if you are here, you will have 1 point. If you are here, half point. But if you are not within this target, you will be 0. So saturated fat should be less than 6% of total energy if you are targeting full mark, or half mark to be less than 11%. And the fibers, we should have fibers, increase the fiber intake more than 14.8 gram per 1,000 kilocalorie if you want to have full mark. So increasing fibers, reducing saturated fat, reducing sodium, increasing potassium intake. But to increase potassium intake, we should be earlier, in the early stages of chronic kidney disease, because as I'm going to mention, it is proven to be effective in reducing the progression of kidney disease. So these are the 9 components of DASH diet. Be in the target, or at least in the intermediate target, because if you achieve above the total score above 5, this means that you are in the healthy side. The DASH diet is associated with improvement of blood pressure, uric acid, the reducing stone formation, and protecting the kidney at the end of the day. A lot of beneficial effects of plants on different organs of the body. So if we encourage plants or vegetarian diet, it is associated with reduce the fat, reduce the carbohydrate, increase the fiber, less animal protein, less phosphorus, less acid load, and less salt. All these are beneficial for not only for the kidney, but also for pancreas, for the heart, and for the health of the human being. Again, encourage plant diet from the early beginning. This is just to show you what's meant by potential renal acid load. This is the diet. If you are in this category, you are in the acid, because acid here is positive. So hard and processed cheese, egg yolk, meat and poultry, all this in the positive acid load. But if you are here raisins in Arabic means zabib, spinach, fruits, vegetables, you are here in the negative acid means the base. As I mentioned in the middle of the presentation, acidosis is bad for CKD progression. This is why if we encourage this fruits and vegetables and the plant in the early life and the early beginning of chronic kidney disease, this will preserve kidney function. For the beverages and drinks, please avoid sugary drinks. And please avoid as well diet soda. Why? Diet soda is harmful. Yes, diet soda may be associated with increased risk of end-stage kidney disease. Why? Because it can disturb gut microbiome. It is rich in phosphate, rich with many points that increase the risk of chronic kidney disease. This is why we educate people against all these habits. So the risk factors for chronic kidney disease and the progression of chronic kidney disease include many risk factors. Some of them non-modifiable, some are either totally modifiable or partially modifiable. So albuminuria, so this is why we use ACE inhibitor or ARBs, and in anti-diabetic treatment, sodium glucose cotransporter 2 inhibitors, hypertension to be treated. For patients with previous history of acute kidney injury, we should be more careful about any other etiology, treating diabetes, avoiding obesity or reducing body weight in obese persons, controlling lipids, stopping smoking, avoiding heavy protein diet, controlling acidosis and avoiding acidosis, phosphate and other. So this is why we like this. The last part of the presentation is primary prevention of chronic kidney disease. I like this article. This is why I have this presentation that was recorded in September in 8 minutes about primary prevention of CKD. What's meant by primary prevention is to avoid chronic kidney disease altogether. And the primary prevention is through healthy lifestyle modification. What are the healthy lifestyle modification that are associated with all these points? These are the vegetable intake, again, proteins, plants, fruits and vegetables are associated with reduction of chronic kidney disease. As you see, the diamond here is less than 1. This means that the risk of chronic kidney disease is reduced by the value. Potassium intake is beneficial, but we shouldn't be late. In advanced CKD, we are afraid of hyperkalemia, especially if the patient is treated with angiotensin converting enzyme inhibitors or ARBs. So earlier in intake of plants, potassium is associated with reduction of incident CKD. Physical activity reduces CKD. So we should should avoid sedentary lifestyle. Sodium intake is red, means that excessive sodium is associated with increased CKD. The diamond here is above 1. This means that CKD is increased if we eat salt, excessive salt. We should avoid added salt. This is at least for the general population. And to know all what we need from salt, sodium chloride intake is just a small spoon that is present in all the foods. We don't need added salt to the foods. Avoid all these bad habits. Tobacco smoking is associated with increased risk of chronic kidney disease and occurrence of CKD. Stop smoking. And if we go to the vision and the mission of the American Society of Nephrology, and because we had Professor Agrawal with us in one of the meetings, and this is the mission of American Society of Nephrology, is not to treat the disease, to prevent. So if we want to be mature, we should change our style from treating toward the prevention of kidney diseases. And the vision is a world without kidney disease. I think it should be our interest. And this is why we educate people everywhere in the villages and by Arabic language, what to drink and how and what is the healthy lifestyle. All these are explained in Arabic for the people. At least if we cannot prevent, we should know how to deal with CKD and allow the patients to live well, to improve quality of life. And this is the theme of the next year World Kidney Day activity. Back to the case, and this is the last slide, and then to have your questions. This is a 65-year-old male patient. We have 3 questions. What is the stage of CKD? I'd like to stop here, and if one of the candidates and attendee answer the question, I'll be very happy.